Hello to everyone. I'm Jessica Goldstein, Education Program Coordinator at ASRM. Welcome to this webinar on repair of Isthmocele. Please join me in welcoming my colleagues Sarah Ramaya, Zach Knight, and today's moderator, Dr. Stephen Lindheim. Before we begin, please note the webinar was developed by the American Society for Reproductive Medicine and the Society of Reproductive Surgeons as an educational resource in service to its members and other reproductive professionals. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentations will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. Dr. Lindheim is a professor of obstetrics and gynecology at Wright State University Boone's Hoff School of Medicine. He currently serves as the associate specialty editor for Fertility and Sterility and is immediate past president for SRS. I'll now turn the presentation over to Dr. Lindheim to introduce today's speakers. Dr. Lindheim?
Welcome, everyone. Thank you so much for taking the time to be with us this evening. Tonight's discussion is going to be presented by two great discussants, Dr. Keith Isaacson and Ali Miraji. We're going to be talking about the repair of Isthmocele, optimal methods of repair, and does it improve fertility outcomes. Please note that the views expressed here do not necessarily reflect the reviews of ASRM. There are no relevant disclosures for any of us and the speakers. And as we move into the next, the first talk, I'm delighted to present Dr. Keith Isaacson, who is an associate professor at Massachusetts General Hospital and medical director at Newton Wesley Hospital. He is certified by the American Board of OBGYN and is fellowship trained in reproductive endocrine and infertility. He has served as president of the Society of Reproductive Surgeons and the president of the American Association of Gynecologic Surgeons. In 2013, he was the recipient of the Distinguished Surgeons Award from the American Society of Reproductive Medicine. It is with great pleasure that he will be presenting this evening on uterine Isthmocele, when and how to repair. Dr. Isaacson?
Thank you, Stephen. I hope everyone can hear me well, and I want to express my appreciation to the ASRM and to Jessica and to Stephen for this invitation, and look forward to a very lively discussion at the end of our two presentations. Well, we've broken this up a little bit between myself and Dr. Murgy, where I'll go through a little bit on the background of the Isthmocele, discuss when you should consider repairing it, and the hysteroscopic repair. And Dr. Murgy is going to go over the laparoscopic repair in greater detail, as well as some of the outcomes. So the first is a definition of what is a uterine Isthmocele, because you hear a lot of different terms used when describing this condition. You've heard it called a cesarean section defect, a niche, and it's really just a pouch-like defect in the anterior uterine isthmus at the site of a prior cesarean section. There is an ultrasound definition, we can talk about it, but approximately 70% of people who've had a C-section actually have a C-section scar or a niche or an Isthmocele. And certainly 70% of people with C-section scars do not have problems with fertility afterwards. So the biggest issue that I think we're gonna have a discussion about is when do you, not only how do you diagnose it, but when is it appropriate to repair it? It was first treated in 2003 laparoscopically, but it was first reported in 1975. The diagnosis most often is made just by transvaginal ultrasound. You can also, it helps sometimes to do a sonohistogram to show a wedge-shaped myometrial defect. and then I'll show you what it looks like by office hysteroscopy as well. When you do the ultrasound diagnosis, it's early. Timing is important. It's best to do it in the early follicular phase, just after menstruation. Again, you see triangular hypoechoic space filled with menstrual fluid. And here are some of the definitions that have been reported by the Journal of Ultrasound Medicine, where you have a myometrial defect greater than 2 millimeters in depth, and a large niche has a depth of 50 to 80% of the myometrium thickness. So clearly this is a transvaginal ultrasound. Hopefully you can see my cursor. This is just easily done in your own office. You see the endometrial echo here. Actually, that's in the cervix. And then here's the defect for the isthmocele, and the endometrial stripe goes down here. So clearly there's an isthmocele filled with fluid. But again, does that necessarily mean that it needs to be repaired? And then if you want to take a look at it, prior to any type of surgical repair, what you'll do is we could do an office hysteroscopy, and this is done with when I do it, it's a vaginoscopic technique, which means there's no speculum, there's no tenaculum, there's no paracervical block. We use a rigid scope, normal saline for distension, and when you do any type of hysteroscopy, you want to make sure you identify both tubulostia, so you know you went all the way into the top of the fundus, and that's what we'll do first. And then what I want to show you on the way back as we pull out, so now we know we're in the cavity, and again, we rotate one side, you'll see the opening to the tube, rotate the other side, and we'll see the other tube. And then most important is when we pull back to identify the isthmocele itself. So now we're in the lower uterine segment. We're going to pull further back. This is almost the opening of the internal os of the cervix. And then here we see the C-section scar anteriorly. And what's important here in this C-section scar, which is I'm going to highlight over and over again, you see the C-section scar is lined by really abnormal endometrium. Its endometrium consisted with lower uterine segment, but this is actually in the cervix. So when you're treating this, keep in mind it's all of these cells, it's the lining, it's the abnormal endometrium, probably much more important than the actual defect itself that needs to be treated. I want to go back 1 second just here, and this was that ultrasound. So when you're trying to decide how you're going to repair this in a patient who needs repair, you're looking here at the apex of the defect and measuring between the apex and the serosa here. And you'll develop your own personal criteria. My criteria is this needs to be greater than 2 millimeters between here and here for me to do this hysteroscopically. If it's less than 2 millimeters from here to here, then she's more of a candidate for a laparoscopic repair. So what are the symptoms? Most patients obviously are asymptomatic. Some people have post-menstrual bleeding that can last for 2 to 12 days. The big question for this discussion is infertility. Does it really impact fertility or embryo implantation? And I think the answer is we're not clear. So in my own personal practice, the time that I repair this for infertility symptoms only is when there's fluid in the endometrial cavity at the time of embryo implantation. So if I look throughout the luteal phase and there's no fluid in the cavity, to me this person is not necessarily a candidate for repair. But if there is fluid in the cavity around the time of when you're planning to do an embryo transfer, then clearly that patient should be considered a candidate for repair. There's really no data showing that repairing the isthmocele is going to reduce the risk of uterine dehiscence, even though we hope that it does, but there's no data to prove that either laparoscopically or hysteroscopically. So who should be treated? We talked about abnormal bleeding. If they have prolonged spotting, it seems to help. There have been a group of patients who felt to have chronic pain due to the Isthmocele. I have yet to identify a patient with that. Again, there's no data to show that it reduces the risk of uterine dehiscence, even when it's a laparoscopic or vaginal repair. And again, when you look at infertility patients and you have to say, does a history of a C-section reduce the chance of pregnancy? Think about the other confounding factors is that this is typically an older age group patient. If they've already had more than one C-section, they may have adhesions, which could contribute to their fertility issues. And then what you're left with is trying to decide, is the niche responsible or playing a role with their infertility? And that's a hard question to answer. So again, this is what we talked about. How could it cause infertility? Fluid in the cavity. It can create a difficult embryo transfer. And then the question is, does it produce any inflammation? How do you treat this medically? Obviously, there's no medical treatment that's going to help a patient's fertility. But if they're having prolonged spotting, you can try continuous birth control pills. The Mirena IUD seems to be ineffective for this. Actually, vaginal surgery, vaginal repair has been reported in over 14 patients. And actually, I've seen videos of it. It's actually a very nice repair. If you can if you're a good vaginal surgeon, you can pull the cervix down, deflect off the bladder, do your repair that way. And they found that in this small report of 14 patients, 85% had improved symptoms with a respectable pregnancy rate. Laparotomy has been reported in 13 patients, with a 2-layer closure, 73% pregnancy rate. But really what I'm here to focus on for the next couple of minutes is the hysteroscopic repair. There have been over 16 publications with the largest series of 77 patients. When you go to large meetings like the ASRM or the AGL, often it's not uncommon to have a group of surgeons who are very dedicated to the laparoscopic repair and feel like that's the only way that it should be done. And there's others that feel it should only be done hysteroscopically. But I think if your skill set allows, you can pick the right approach for the right patient, given the amount of tissue there is, again, between the apex and the bladder. The pregnancy rates are similar, both laparoscopic and hysteroscopic repair, and the failure rates are also similar, which is about 11%. So the hysteroscopic technique, again, most importantly, if you're going to do this, do your own vaginal ultrasound or saline sonogram. Only attempt, at least in my hands, if the myometrium or that cervical stroma is greater than 2 millimeters between the apex of the defect and the bladder. And 2 millimeters is not a lot of tissue, as you know. Now, when you start this, I resect, and my goal here is almost to do like an endometrial resection, but I'm just doing it in the C-section scar. I want to remove all that abnormal endometrium that's lining the C-section scar that I think is producing the fluid and obviously produces an environment in which an embryo can actually attach and cause a C-section ectopic pregnancy. So when you start this procedure, just to kind of, as you're warming up, and the safest area to start is start in the right and left lateral sidewalls. And then when you're feeling pretty good about your technique and about how the equipment is working and your settings are right, then you finish up with the apex with a fine bipolar loop electrode to the myometrium. So again, these are some data, prospective data on the hysteroscopic treatment. Again, what you're trying to do is to really remove this layer here, just this white layer. You can flatten this out, but I'm more and more convinced it's really not the defect that's the problem. I truly believe it's the abnormal endometrium that lines the defect that has to be treated. So here is, again, ultrasound, transvaginal ultrasound. You can see the fluid here, but you can actually, as you're watching sometimes, you can actually see the fluid in the cavity and it will kind of, as the uterus contracts, it will kind of come and go. So sometimes you, again, if you're doing this yourself, you don't necessarily want to just see a static image. You actually want to see the fluid in here, and then just watch it for a little while, and you'll see that uterus contract, and it can come and go. So it's important that you do this yourself. And again, this is a very easy one to see the apex and to see the serosal where the bladder is, so you can make a decision as to which way that should be repaired. I want to show you, not this one, but this video. And this is an unedited video, and it lasts about 6 or 7 minutes. So we can think about it, ask any questions that you might have regarding this video and the technique after looking at this particular procedure. So we were started in the cavity. We saw both tubes. We're pulling back. And as we're pulling back further and further, you now start to see the C-section scar. And look at the lining of this scar. Again, all this endometrial tissue, which should not be obviously in the cervix, needs to be resected. Now, I use this is normal saline. It's a bipolar loop electrode. My preference is I use this Irby generator. The new Irby generator that we just purchased has an impedance feedback rate of 24 million times per second. And the old one used to be 14,000. And how that translates into being clinically useful is that there's actually no delay on initiation of the cut, and you can cut just a cell layer at a time using this particular generator, which I found to be very helpful. So again, I started on the patient's left side wall, then I go to the right side wall. Now I'm pretty comfortable with my settings, because the most crucial part of this procedure is obviously at the apex, where you're the closest to the bladder. And my goal here is I want to remove every single bit of that abnormal endometrium that's lining this C-section scar. So even you'll see that little red spot. I'm not going to leave that. We're going to get every piece until the whole thing is treated. And I have colleagues in Europe who are now doing this, where they're resecting not only the anterior defect, they're resecting the posterior cervix. I don't understand the logic behind that. You may hear about it. They've been fortunate not to create ASRMs and close off the canal, but that's just not a technique that I've adopted as of yet. And we're just about to finish up. But I want to just show you the end, where again, we will have absolutely none of that normal endometrium. Now, afterwards, I tell the patient that they should let this heal for 2 cycles, and then I'll recheck their cavity by ultrasound after 2 full cycles. And if there's no fluid in the cavity at that point, then they can proceed with their transfer. So this whole procedure, again, this is unedited, took about, I don't know, right now it's at almost 4 minutes, and that's all it takes. But, like most surgeons, when things go so quick, we just start cutting extra tissue just because we're so happy with ourselves. But this is what it should look like at the end of the procedure. So, Stephen, with that, I think I'm going to delay and we'll take questions at the very end. And I look forward to seeing Dr. Murgy's presentation on the laparoscopic approach.
Perfect. Well, Keith, that was excellent. Thank you very much. Dr. Ali Murgy is going to now be speaking to us on cesarean scar defects from a laparoscopic vantage point here. If you just give me 1 second here. Dr. Murgy is a associate professor of obstetrics and gynecology at the University of Toronto with a focus on advanced pelvic surgery. He's recently completed a master's in public health from Harvard and has a keen interest in outcomes research. It is with great pleasure that he's going to be presenting tonight, and we look forward to his laparoscopic approach to these disorders. Ali?
Perfect. Thank you, Dr. Lindheim. Can you hear me okay? Oh, good. And we see this. We see the screen. Okay. Thank you very much for inviting me today to speak. Thank you to ASRM. Thank you to Professor Lindheim and the entire team. It takes a lot to put this together. So the team that's really been working behind the scenes. So Dr. Isaacson's done an excellent job in talking to you about the hysteroscopic approach. And my goal today in the next few minutes is to review the laparoscopic approach to cesarean scar defect repair and to really develop an approach to the symptomatic isthmocele and figure out, what do you offer, when do you offer it, what are the clinical nuances that go into triaging patients. And the third thing is I want to touch a little bit on one of the reproductive complications of a cesarean scar defect, and that's the cesarean scar pregnancy and how we approach that and treat that. So the big question here is, when do you consider a laparoscopic approach? So number one, I think that if there's one thing that you take away from this webinar today, and Keith said it in his presentation, and I'm going to say it a couple of times also, is that 70% of women who have a previous cesarean section will have a cesarean scar defect. The presence of the cesarean scar defect doesn't necessarily mean that it needs to be treated, no matter how it looks really on ultrasound. And a lot of these things are picked up incidentally. The treatment really is, and when you want to offer treatment, it's really for symptomatic patients. The laparoscopic approach is when the residual myometrial thickness is less than, I'm not so brave as Keith, and I would usually say 3 millimeters. But again, there's no consensus in the literature. Some will say less than 2 millimeters, some will say less than 2.5. I use 3 millimeters, I'm not as bold. But when that residual myometrial thickness is thin, is when you want to approach this laparoscopically. And because surgery and laparoscopic surgery for this is riskier than the 6-minute approach that Dr. Isaacson showed you, I usually will offer this for failed other treatment options, especially in the context of abnormal uterine bleeding. The goals of this isthmocele repair is essentially, there are 4 steps really. The first step is a bladder dissection. So you want to bring the bladder down and reflect it so that you expose the isthmocele. The second step is to identify the anatomy, and then is to resect the entire isthmocele and then suture the defect in either 1 layer or 2 layers. So I'm going to take you through a video of this. So the first step is really the bladder dissection. Now I always start laterally and open up the pair of vesicle spaces. And the bladder is usually scarred in the middle, so I usually go from one side to the other. And here you can see how the bladder is really on top. I want to pause here just for 1 second. This is a quick trick. Instead of putting in methylene blue into the bladder, you can do cystosufflation just to see exactly how far your bladder is coming up, and that allows you to dissect appropriately. So you can see here we're putting in air into the bladder, and you can see that the bladder's not where I'm dissecting, so it allows you to delineate the margins. And then as you go from lateral to medial, it's the middle part that's really scarred, and that's the part that you take down last. Once the bladder has been resected, The second step is really to identify the isthmocele. And here we do a combination of a laparoscopic and a hysteroscopic approach. And here you can see the light of the hysteroscope laparoscopically, and it really illuminates the entire defect, because the goal of this procedure is to really resect the entire niche in order for you to get good repair and really buttress that anterior cervix and the lower uterine segment. So once we have identified the pouch-like defect, this is you can do it either through a hysteroscope, or you can do it with a Hager dilator, where you just take the dilator and scrape it against the anterior uterine wall and anterior cervix to identify the defect. And then what I do is I mark the defect with monopolar electrosurgery. And then I usually go from caudad to cephalad. We enter the uterus, and then we're able to resect that entire defect. And you can see here, and again, I'll pause for 1 second. You can see here on the endometrium, that's the same endometrium that Dr. Isaacson showed you hysteroscopically with the abnormal vasculature and the fistulous tract. And this tissue, which has been taken off to pathology, usually shows adenomyosis, endometriosis, adhesions, inflammation. And so this is really the only approach that excises that tissue. And so patients who are having pain, excising this sort of defect is probably can be helpful for them. We, in our practice, use barbed suture, but you can repair this any way you like. I do a 2-layer closure using barbed suture to really bring together that lower uterine segment and essentially thicken up that residual myometrial thickness. So again, the steps are the bladder dissection, going from lateral to medial, identifying the anatomy, because you really want to resect the entire isthmocele. You resect the isthmocele and then you suture the defect. Key points are is that surgical management, laparoscopic isthmocele and isthmoplasty is indicated for symptomatic patients. I get a lot of referrals from my obstetrician colleagues saying that this is a very large isthmocele, a very thin and a very thin overlying residual myometrial thickness, and can you fix this prior to the patient getting pregnant? But we have absolutely no data that shows that fixing the isthmocele pre-pregnancy actually prevents, as a prophylaxis, actually prevents adverse obstetrical outcomes. So we have to be very careful in these situations because there's very little data guiding us. Laparoscopic approach works well. There's symptom improvement from 80 to 100% based on the studies. And when you look at the studies, of course, there's significant publication bias, and it shows no intraoperative complications. But you can see from the video that I demonstrated that the bladder can be quite adherent. And it is not unreasonable to see bladder injury, at least at the dome, if you get into the wrong plane. So that is a risk that you must definitely discuss with patients. And then it's the best surgical approach for patients who desire future fertility and with the residual myometrial thickness of less than 2 to 3 millimeters. The pregnancy rates are between 25 and 70% of patients achieve pregnancy. So now you're thinking, we've touched a little bit on medical management. Dr. Isaacson showed you the hysteroscopic management. I've gone through the laparoscopic management. How do these various treatment options really compare? The first step is medical management. It's the least invasive. There's extremely limited data on the combined hormonal contraception, and even less so on the levonorgestrel intrauterine device. There's only one study on it with moderate effectiveness, really. We have level 1 evidence. There is a randomized controlled trial that looked at medical management or expectant management also compared to hysteroscopic approach. And so medical management we know is less effective probably than surgery. But of course, because it is the least invasive, it is something that I offer to my patients as first line. And of course, there are patients who don't want to take medical management, or patients who have contraindications to medical management, and then we visit the surgical options. With respect to the hysteroscopic approach, again, as we showed you, it's a 4 to 6 minute procedure if everything goes well, so it's minimally invasive. It's day surgery, and it really promotes the elimination of that hematocele, that fluid that's built up, because essentially you're taking the cephalad ledge and you're taking the caudad ledge, and you're essentially smoothing this out. And I tell patients here, we're making this little mountain essentially a hill, where it promotes the evacuation of that fluid that builds up every month. And it's been shown to be effective for abnormal uterine bleeding. The issue with hysteroscopy is that it doesn't change the anatomy very much. You're not going to increase that residual myometrial thickness. And you do need a residual myometrial thickness of at least 2 to 3 millimeters in order to even proceed. Because you have to be careful, because the bladder has not been dissected, and it may be easy to cause thermal damage or even perforate into the bladder. With laparoscopy, you see everything, so that is an advantage. The outcomes are very good when you look at the meta-analysis, and I'm going to show that to you. And it is the only approach, apart from the vaginal, that actually alters the architecture and the anatomy of the lower uterine segment and the upper cervix, because it definitely buttresses that myometrium and improves the residual myometrial thickness. And it promotes complete excision in patients who definitely have pathology in that cesarean scar defect. The issue with it is that it's invasive, and there's definitely that risk of bladder injury. With respect to the vaginal approach, it is less invasive than the laparoscopic approach, and in the skilled hands, it can be quite effective. I don't have very much experience with this. The issue is that it is a narrow surgical field, and bladder scarring is an issue because these patients have had previous cesarean sections. So to be able to, again, get into that right plane, you have to be a skilled vaginal surgeon. And then it may be actually quite difficult to excise the entire defect, because then you're really relying on a probe in the isthmocele base to exactly map out where it is. There was a recent meta-analysis, and this was a systematic review and a network meta-analysis that looked at randomized controlled trials and observational studies, looking at the various different approaches and tried to compare them. And when we look at the outcome for the efficacy of treating abnormal uterine bleeding, the laparoscopic approach combined with hysteroscopy, as I've shown you, was far more effective and significantly more effective than the hysteroscopic approach alone, and also more effective than the vaginal approach. Again, I draw your attention to the fact that this is based on 2 studies when you compare hysteroscopy to laparoscopy with 110 patients. And when you're comparing vaginal to laparoscopy, it's more studies, and the majority of these really have been done in Asia. So what about pregnancy rates? This is perhaps the most controversial or the most difficult in order for us to tease out the data, because there is such a lack of standardization in the inclusion of patients in these various studies. In terms of what type of infertility do these patients have, what were their causes of infertility, we don't have good quality studies. We don't have randomized control studies when comparing these various approaches. And so we're only left with respect to what outcomes that have been reported by these various authors. And sometimes they report pregnancy rates, sometimes they report take-home baby rates, miscarriage rates are inconsistently reported. And so these are the rates in the literature: 6 to 10% to 100% with hysteroscopy, 20 to 75% with laparoscopy, and about 40% based on one study for the vaginal approach. So then the question patients will ask us is, when can I get pregnant? Because everybody's in a rush to get pregnant after their surgery. And the long and short of it is that we have absolutely no idea. In 2018 in JMIG, there was a global congress of and the Hysteroscopic Scientific Committee came up with a consensus statement. And they said that, and they acknowledged that there's a lack of evidence for sure, but we need to counsel our patients somehow. And so they are recommending that we encourage patients to wait for 3 or more months post-operatively to conceive. And I'll be interested to see what Keith has to say on this with respect to his patients in the Q&A session later. And they do recommend delivery by scheduled cesarean section no later than 38 weeks. And perhaps some of the data here has really been extrapolated from some of the data with respect to the myomectomy data. But this is what I'm telling my patients following both laparoscopic and hysteroscopic surgery. I'm going to take you through a decision tree. So you have a patient in front of you with a symptomatic cesarean scar defect, can be either infertility, abnormal uterine bleeding, or pain. And I find that some patients, a lot of patients actually come complaining to me with either mid-cycle central pain or post-menstrual pain because of the fluid that builds up in that lower uterine segment in that cesarean section scar. So my first question is, do you wish to conceive or you have no plans to conceive? And in the patients who have no plans to conceive, the first line option that I will offer is medical management because it is the least invasive. Then I think to myself, on imaging, I do a sonohystogram. Is the residual myometrial thickness less than 3 millimeters or greater than 3 millimeters? And in the patients who are less than 3 millimeters, they can go to either laparoscopic repair if they want uterine conserving surgery. But a lot of patients have a significant impact on their quality of life with this, especially the large isthmoceles. They can be extremely symptomatic from this. And I do want to remind the audience here that a laparoscopic hysterectomy is an approach that may be discussed with patients who may not want to go through some of the other aspects where there may be failure rate. If your residual myometrial thickness is more than 3 millimeters, a hysteroscopic repair, plus or minus a levonorgestrel intrauterine device put in at the same time. For those patients who are wishing to conceive, if the residual myometrial thickness is less than 3 millimeters, I would offer a laparoscopic repair. And those who have a residual myometrial thickness of greater than 3 millimeters, a hysteroscopic repair. And of course, if there's still increased fluid in there, and my fertility colleagues are having a issue with respect to embryo transfer because of persistent endometrial cavity fluid, then you can always go to a laparoscopic repair following that. The issue is that these patients are so anxious to get to their embryo transfer that this does delay things. I want to spend the next few minutes talking a little bit on the early pregnancy complication of cesarean scar pregnancy. And I think the one take-home message that I do want to give everybody here is that this is perhaps a cesarean scar pregnancy, which is a pregnancy in that niche, is on the spectrum of the placenta accreta spectrum disorders. It is essentially a cousin of that and a very early version of that, and I'm going to show you that in some of the video and photos. The sonographic criteria is that the pregnancy is located in the anterior uterine isthmus. There's an empty uterine cavity which does not contact with the gestational sac. There's an empty cervical canal, and there's discontinuity in the anterior myometrium. And so this is a photo that we published in a very large 14 week size lower uterine segment pregnancy, which is in the C-section scar. So it's a C-section scar defect. You can see the placenta is well formed here. You see the cervix here, which is empty. You see the fundus here, which is empty. There's no connection between the two here. And you see this big pregnancy in the anterior uterine wall. And so there are two types of cesarean scar pregnancies. There's the type 1, which is the pregnancy that grows into the uterus, and it depends on where the pregnancy is growing. The type 1 pregnancies, and we've seen quite a few of them where we actually counsel these patients that the natural history for the type 1 cesarean scar pregnancy is that these pregnancies continue and essentially become morbidly invasive placenta or placenta increta and percreta. And then these patients have these patients will have an elective cesarean hysterectomy. The type 2 cesarean scar pregnancy is one that grows into the abdomen, and this is really an emergency because these do need to be treated in the first trimester when they're diagnosed, because the natural history here is a predisposed rupture, usually in the mid-trimester. And you can see how this essentially does look like a mini percreta. How do you treat this? Initially in our practice, we were treating them all medically with KCL and then multi-dose methotrexate, but we found that 50% of our patients were coming back with significant amount of bleeding and having necessitating emergency surgery. And this was confirmed by the systematic review published in FNS a few years back that recommended really a surgical approach to a cesarean scar pregnancy. And it said that based on the evidence that was available at the time, that these are laparoscopy, hysteroscopy, the various different approaches are what should be the first line treatment for this condition. And it should the treatment should be based on the availability, surgeon expertise, and really the patient's symptoms and their what they want for continuation of their pregnancy. In our center, we have a protocol for cesarean scar pregnancy because we're a tertiary referral center for them. If we diagnose it based on the ultrasound, based on the criteria that I shared with you, the question we ask ourselves is there a fetal heart rate or not? If there is, we do an interventional radiology guided KCL, and then we wait for about a week to allow that, pregnancy to involute. And then we go for surgical intervention. The surgical intervention includes the laparoscopy and internal iliac artery ligation, and then we reflect the vesico-uterine peritoneum and confirm the type of pregnancy it is. If it is a type 1 cesarean scar pregnancy, we'll do vasopressin, we'll do a hysteroscopy, and then a suction DNC under laparoscopic vision to repair that. And then what we'll do is we'll repair that defect at the same time laparoscopically if that patient wants to get pregnant in the future. For the type 2 cesarean scar pregnancy, we'll essentially put in vasopressin and then resect that pregnancy. And I'll show you a video here quickly of that. This here is a patient where there's a type 1 cesarean scar pregnancy. The bladder has been reflected here. We go with hysteroscopy and we confirm the placement and that this is actually a type 1 pregnancy. It's growing inside the uterus and it is in the anterior part of the uterus. And essentially we'll do a DNC and you can see how thin that, that base of the isthmocele is there as we're evacuating that pregnancy. But the bladder has been taken down, so the bladder is actually quite safe here. For the type 2 pregnancies, we'll take down the bladder, and you can see here, initially this is without the reflection of the vesico-uterine peritoneum. This is the uterus here, and the pregnancy hue can be seen here. But once the bladder has been reflected, you can see this very large pregnancy in the cesarean scar defect. This is a type 2 pregnancy that does need to be treated. Here we reflect the bladder right down to the pubocervical fascia. We isolate the cesarean scar pregnancy, and then we'll resect that pregnancy and suture the defect. So I have two concluding slides, and this essentially goes over what Keith and I have tried to impart to you over the last few minutes. The cesarean scar isthmocele is a common radiological finding. Its presence does not mean that the patient is symptomatic. The first line is really a transvaginal ultrasound or a sonohystogram, and usually to wait at least 6 months after that initial cesarean section to allow for healing of the cesarean section scar. And standardized reporting diagnostic criteria are needed, and really the most important part to look at is that residual myometrial thickness and that distance to the serosa. Treatment is only indicated in symptomatic patients. Consider hysteroscopy if the residual myometrial thickness is anywhere between 2 to 3 millimeters, and laparoscopy if it's more than that and or failed other treatments. And hysterectomy is always an option for patients who have significant impact on their quality of life and want definitive management. So at this point in time, I'm going to hand this back to Dr. Lindheim for any questions that you may have.
Thank you. We will now open up the floor to questions for our panelists. Please send in your questions through the question chat box located in the gray toolbar to the right or bottom of your screen. Dr. Lindheim will moderate the session.
These were excellent talks from both of you guys. Great. You know, I'm always learning a great deal. What I'd like to do is I'd like to take some of these questions that have been posed to us and break them into sort of three categories. One is diagnosis, two is procedural for both the hysteroscopic, laparoscopic approach, and then the outcomes. So I'm going to try to posture the questions that have come in that way. The first is we use this arbitrary cutoff threshold of 3 millimeters, 2 millimeters. Can you guys, maybe put up an argument as to why you're picking one number versus the other number for the audience to determine whether we go hysteroscopic or laparoscopic approach? Keith, you want to start it off, if that's okay?
Sure. So for me, it all depends on your level of comfort and your goal of the therapy. So again, I want to get back to the point where it's interesting to me that you have the laparoscopic approach and the hysteroscopic approach give you similar pregnancy outcomes, the best we can tell with the data we have. But yet they leave you two different anatomic defects at the end of the procedure. So at the end of a hysteroscope, you still have a thin myometrium between the apex and the bladder. You still have an area that can accumulate fluid if it's just an anatomic defect that's the problem. With the laparoscope, obviously you close that, but yet you have the same results, and no matter which approach you take. So again, I think the goal here is to resect that lining of the C-section scar defect. So it depends on your level of comfort, and everybody has to choose that themselves. For me, I've decided I'm comfortable resecting with a 2 millimeter margin. I wouldn't argue with anyone who says they're comfortable resecting 3 or 3.5 millimeters. If the key is to remove that tissue in the safest way possible for the patient, because I think I've concluded that the outcomes are very similar when it comes to infertility. So I've elected with my hysteroscopic skill level that I'm going to choose 2, but everyone I think should, since it's not based on science, needs to come up with their own comfort zone.
Ollie, can you comment on that? Is there any scientific basis for that other than comfort?
Yeah, so I would also add that depending on the modality that you're using to diagnose it, that residual myometrial thickness also changes a little bit. So if you're doing a sonohystogram, I find that with the sonohystogram, it all opens up and it actually looks smaller than it actually is. While on transvaginal ultrasound, I find that it's a little bit, it's more collapsed, and I usually get a higher residual myometrial thickness. I echo Keith's sentiments on this, and essentially I kind of put it back to when you're resecting a myoma hysteroscopically, you always think about that residual myometrial thickness. And for me, it's that 2 to 3 millimeters again, also where I will do it under laparoscopic guidance versus just going in hysteroscopically. When you look at the literature for those who are for the studies looking at the hysteroscopic approach, you will see anywhere between 2, 2.5, and 3, depending on, with respect to the inclusion criteria, depending on the center, depending on the surgeons.
No, that's a great point, and actually the sonohystogram and the pressure is an excellent point too in terms of changing the depth. Let's focus on the hysteroscopic approach if we could first, and Ollie, please jump in as well because I know you're doing both methods as well. Keith, can you comment for the audience regarding the degree of the hysteroscope that you may consider using or you should use as you're doing these procedures?
Well, my preference, again, it goes down to personal preference. I always use a 12-degree hysteroscope because that way I can see my loop is in a more similar plane to my lens than when I use a 25 or 30 degrees. So I use a 12-degree scope. I use either one of 2 resectoscopes, either a 21 French bipolar resectoscope, which is relatively small. And now they've come out with a 5mm resectoscope that I've also used for this. So I'm using again, it's relatively small loops. And most important to me is the generator itself. So you need a good generator so that you have good control. And there is no thermal damage when you're using the cutting current, into that myometrium, because the bubbles that you're creating when you're cutting and creating that steam and vapor actually acts as an insulator. So you get much less thermal damage on that cutting current than you would if you were using a coagulation current. So you can actually be very fine and do a layer at a time.
Ollie, do you have any comments regarding that?
Yeah, so I don't have access to some of these fancy new toys that Dr. Isaacson's talked about. I have a traditional 10mm monopolar resectoscope. I think it's challenging because you're operating often in the cervix. You really have to bring that hysteroscope down to the ground because you're operating anteriorly. I also do caution that because there's sometimes fluid leakage and you're operating so close, there's a risk of capacitance coupling also. So we've seen also a burn on the vagina for that. I'm not sure, Keith, if you've seen it, but when you're using a bipolar resectoscope, that's not an issue. For the monopolar resectoscopes, the traditional instruments that we have, that can be an issue, so something to think about. But I found it to be, I can do it with that instrument also. I'd like to add in there with what I do is I also, once I've resected the caudate and the capillate edge, I use a roller ball and essentially just touch some of those aberrant vessels in the endometrium in the base of the isthmocele. Keith, I'm not sure if you do that.
Yeah, the problem you have there, I want to comment on a couple of things. Number one, they're not fancy toys, okay? Bipolar resectoscope was introduced in 1995, and it clearly is the standard of care. And if you don't have it, it's really not fair to your patients that you'd be operating with hypotonic solutions in this day and age. I'm a firm believer in that. It actually is much less expensive than the tissue shavers that I know are used in Canada frequently. Second, and then you don't have the capacitance coupling, you don't have the issue with the fluid monitoring. When you use a roller ball, you're getting much deeper thermal damage than when you're using the loop, because you're actually desiccating the tissue, and the thermal energy will go into the tissue further. So you've got a much greater risk, not a much greater risk because there's very small risk of burning the bladder and injuring the bladder with a roller ball than if you could actually just shave a layer at a time. So I have a lot of colleagues in Canada who are still using monopolar. It's my mission to try to get you guys over to bipolar as soon as possible.
Amazing. You know my chief well, so you'll have to.
Yes, I do.
So
it's a mission.
And I was going to comment about the roller ball and the potential indications of utilizing it. But if we could turn our attention over to the laparoscopic approach, the question would be, is there a time that you would consider doing occluding the uterines if it's a fairly extensive cesarean scar? At what point would you consider just occluding to minimize potential bleeding?
So in my experience, so I do that prophylactically for all the cesarean scar pregnancies because they bleed significantly. And I find that without it, we have significant bleeding. With respect to removing the niche in somebody who's non-pregnant as an interval procedure, I haven't found significant bleeding, although it depends on really how lateral you're going. And so what I've found is that once I incise in the caudally, I'm able to lift it up and see exactly where we're going. And this is where some of our, we do have either a 30-degree camera or the flexible scope allows me to kind of see around the corner to shave it so that we don't go so laterally into the cervical branches. So I haven't had to occlude the uterine artery in an integral or non-pregnant CSD repair.
Keith, any comments?
I agree with him. No, it's a relatively avascular area. You know, that it's not uncommon, and when you go back for a repeat C-section, you see that it's actually dehisced with no bleeding. So I agree with Ali. I haven't experienced any occasions where we've occluded the uterine arteries for bleeding.
What about another question is indications for doing cystoscopy if you have extensive scarring in the lower uterine segment?
You should always do cystoscopy. I mean, there's absolutely no reason not to. So to do cystoscopy.
I agree. If you're worried.
Yeah.
Okay. Another question is in terms of closure, would you consider PDS as opposed to the barb suture?
I don't know. I think that's the long and short answer. We don't have the data on which suture is better. We also don't have the data on whether or not a 1-layer closure or 2-layer closure is better. It seems that in the meta-analysis, the 2021 in JMIG, a lot of the heterogeneity in the studies have been because of the different closure techniques that the various studies have used. So I think that we don't have the data. I'm using barb because it's easy and fast. But I'm not sure, Keith, if you have
your barb suture we use is actually PDS suture, so it is absorbable suture. It just has little barbs in it. But so yeah, it's the same. So the question is, do you need Proline? That's something permanent? No, I don't think you do. I'm not even sure how that would work in pregnancy. So the barb suture is PDS, and you could use Vicryl, has been reported as well. So those are really the only two that I've seen reported.
So another question is, if one of the risk factors for this defect is the single layer closure at cesarean section, why are we still performing a single layer uterine closure? Ali?
We'll have to ask our obstetricians about this. And I think that what the participant is alluding to is the risk factors for a cesarean scar defect, which is single layer closure. Sometimes we know that locking increases the risk of cesarean scar defect. And I think that, first of all, we need excellent evidence that it works, and then we need the knowledge translation piece.
So just because we're closing in on time, but let me just throw out a couple of other questions that were here. Post-operatively on the hysteroscopic approach, are you using higher dose estrogens? Are you using birth control pills? The flip side is to minimize estrogen versus a high dose estrogen to cause a regeneration or a healing process, or are you even going as far as extremes of using a Lupron or a GnRH agonist for this?
None of the above. So there's no estrogen at all that I give for this. Clearly don't give any extreme forms of estrogen, don't give any Lupron or anything else. No, I just let it heal, particularly in a patient who has who's ovulating, has normal estrogen levels on her own, is not hypothalamic or anything like that. So it's been very interesting. There was a large series published down in the Netherlands that even showed after Ashman's patients that giving high dose estrogen is of no value in patients who have normal estrogen, serum estrogen levels on their own. So I'm even cutting back on the Ashman's, but on this particular circumstance, I don't give any post-op hormonal therapy.
So in terms of outcomes, and Jessica's going to probably cut us off at some point if we're getting closing in on the end, but in terms of outcomes, have they been able to discern differences? And this is one of the questions that has come up, is, and I'm going to actually posture two potential questions here. One is the indications that we go ahead and we do a repair is that we see fluid, or that we may have difficulty getting an embryo transfer catheter in. Has anybody looked specifically at outcomes related to those variables separately than lumping everything together? And then the second question is there any concerns with abnormal placentation with hysteroscopic repair? And I have one other final question here, if we can squeeze it in, is that for the cesarean scar pregnancies, one scenario is having a normal intrauterine pregnancy and the heterotopic in the cesarean scar. How do you treat it? So can you jump and answer those as quickly as you can? You want to take a stab at those? Because those are all great questions.
Oh my gosh. With respect to the cesarean scar pregnancy, I've never had a heterotopic pregnancy. We have had twin pregnancy where there is there's an invasive placentation, and usually that has proceeded on to third trimester with the elective cesarean hysterectomy. Your middle question was, I'm blanking on it again, whether or not, oh yes, whether or not repair has actually been associated with abnormal placentation, cesarean scar pregnancy in there. Absolutely. So we've had, in my experience, we've had both laparoscopic and hysteroscopic patients who have been repaired who have ended up with invasive placentation, and one with repeat CSP. And the first question, Keith, do you wanna take it with respect, I believe,
I think the first one is, are there better outcomes for difficult embryo transfer versus a fluid in the cavity? I have not personally done any for difficult embryo transfers as a sole reason. I've only done them for those who've had the fluid in the cavity at the time of implantation. So, you know, typically now with good abdominal ultrasound guidance, the issue of a difficult transfer due to this particular problem has been minimized. So I just don't have any experience for that indication.
There are a lot of great questions, and I wish that we can comprehensively get through all of them. I know that Dr. Meraji and Dr. Isaacson and even myself are available to any questions through email that anybody may have. This was an outstanding interaction, and I wish we had more time for questions. Thank you very much for spending time with us this evening, and for all those viewers as well. And until next time, I guess we're going to sign off, everybody. Thank you very much.
Take care. Thank you. Great job, Steve.
Thank you to our panelists and attendees. You will receive a survey by email after the session. Your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded and will be available on our website in the near future. Please watch your email for notification about future webinars. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.